John Mulhall, and I hope I pronounced it as it should be pronounced, is the director of both the Male Sexual and Reproductive Medicine Program and the Sexual Medicine Research Laboratory at Memorial Sloan Kettering Cancer Center in New York City. He holds an adjunct position as professor of urology in the Department of Urology at Weill Cornell Medical College. He's the editor-in-chief of the Journal of Sexual Medicine and the author of Saving Your Sex Life, a guide for men and prostate cancer. John is a marvelous, amazing speaker, and we're very, very happy and thankful that you are here with us today.
Well, first of all, it's my pleasure. Usually I'm very energetic, and I start off lectures in a very good mood. But today, of course, I want to start talking about Renan, of course, and that's very sad. So I'm going to share my screen. Okay, is that possible? Yeah, good. Can you see my screen? Yeah. So I started, I graduated from Irwin Goldstein's fellowship in 1996, and I started in Chicago. I spent 6 years there. Then I moved to New York, 2002, and then I started a fellowship in 2005. I was combined between Cornell and Memorial at that stage. So it's a 2-year fellowship. So my second ever fellow was Renan. I never had plans to take an international fellow. There are enough American fellows out there who want this position. So Renan impressed me from almost the first minute that I spoke to him. As all of you know, he has an irrepressible enthusiasm, almost had a childlike enthusiasm. And of course, he had that incredible baby face. No matter how old he was, he still looked like he was 25. So Renan, this is, I've got a couple of photographs. Thank you, Michal, for sending the photographs. So this is a photograph taken. I'm not sure where this is taken, but this is classic Renan about to present at a meeting kind of mode, kind of the intensity of Renan Tal in his nice suit and tie. He was born in 1968 in Hedera. Yehezkel and Penina are his parents, and he has an older sister, Batsheva. Not surprisingly, he excelled in school, of course. He excelled. He was incredibly bright. At 15 years of age, he volunteered for the Israeli Emergency Medical Services, Red Star of David. He started pre-military academic studies at the IIT as an electrical engineer. You can see him being an engineer because he was definitely an innovator in the operating room, and he was incredibly meticulous. And he strikes you as he would be like a good engineer. But he changed his mind, and he decided to be a physician, and he left IIT. He did 3 years of medical service in the Army Medical Service as a paramedic. And after military service, he began his medical school training at Tel Aviv University. Sorry. He financed himself through medical school as a paramedic part-time, waiting tables and teaching, prepping people for SAT tests. He finished his medical degree with excellence, again, not surprisingly. Interestingly, his MD degree thesis was on male infertility. He spent a year, he started his residency at Rabin Medical Center and then spent a year at Memorial doing research. He was assigned to the cancer doctors, but very quickly gravitated over towards me. And he was, literally brilliant. And we hit it off very well. And so right there and then, it was clear to me that he'd be an excellent fellow with us. And in 2007, my second ever fellow, he came and he spent 2 years with me. After that, he returned to Rabin Medical Center to develop the andrology services there. And then not too distant past, he moved from Rabin to Rambam in Haifa to do the same thing there. I think he had a very successful practice. It was very interesting to me. Mentorship was a very important part of my life, my academic life. And he struggled with the tension between being an academician and being in private practice. He would talk all the time about how he wanted to service people, serve them, and how he was so busy and he wanted to be available, but he loved writing and researching. And we never really resolved that tension, and unfortunately he passed away in 2019. But he had a mind that he could have easily been an absolute world authority if he had wanted to be. These are just a list of the medical societies that he belonged to. He presented for me at the Sexual Medicine Society of North America, at the International Society of Sexual Medicine, at the American Urological Association, at the European Association of Urology. And June 12th was a very sad day. So I'll leave it at that before I get too emotional. So it's my pleasure to talk about, this is the classic Renan photograph on the podium. And not alone did he present beautifully, not alone were his slides always perfect, but he was really talented at handling questions from the floor. So he was a natural. So Michal and I spoke, and we decided that we would talk about orgasmic disorder after radical prostatectomy or radical pelvic surgery in general. I have no disclosures in this area. I have no disclosures whatsoever. I always like to start these talks with this phrase: it takes 50 years to get a wrong idea out of medicine and 100 years to get a right one into it. The wrong idea is that, Mr. Jones, I've removed your prostate, your PSA is undetectable, so you should be happy, right? And the right idea is that we need to stop being so oncocentric, and we need to stop focusing success entirely on a PSA level, when quality of life is critically important. I think all of us in the specialists who are in the society know that, because that's what we do for a living. There's another famous phrase which we should not focus on adding years to life, but we should also focus on adding life to years. And I think this is especially true in the prostate cancer population. There is a host of issues that occur orgasmically in the radical pelvic surgery patient, particularly the prostatectomy patient. And we'll deal with most of these here. Orgasmic pain, incontinence, and FASA, which is primary headache associated with sexual activity, are not only seen post-prostatectomy, but the pain and incontinence are mostly seen in men after radical prostatectomy. So they're fairly unique to the prostatectomy group. If you look down this list, this is a reasonable representation of the literature that exists out there in men who've had a prostatectomy, mostly radical prostatectomy, but sometimes TURP. And you'll see there's really not a lot of literature. Cancer centers are very cancer focused. I work at one of the most famous cancer centers in the world. And even here, the urologists are super PSA focused, and the medical oncologists and the radiation oncologists. So the literature is not particularly replete, but you can get a flavor that orgasmic problems are not uncommon after radical prostatectomy. So there's very little literature on this. This is a study we did many years ago when I was at Loyola University in Chicago. We put together a questionnaire. It wasn't validated. There is not really a good orgasm questionnaire unless you're going to use some of the very, very long questionnaires that have 250 questions in them. There is not a very focused orgasm questionnaire for men. 230 men, 12 months or more after surgery, and this is the breakdown. So 22% had no change in orgasm intensity. So it's the minority of men in my practice now who say there's no change in orgasmic intensity. A third had a complete absence of orgasm despite sexual activity. So 1/3 of men post-prostatectomy who are after 1 year after surgery or longer, had difficulty having any orgasm. About a third had reduction in orgasmic intensity, and very interestingly and consistently throughout my 25 years in the business, 4 to 10% of men have a more intense orgasm after prostatectomy. It's quite remarkable. This is consistently that rate of men that come in. I see them most days or most weeks in my practice. My orgasms are more intense, and I've no idea, and I haven't heard a good explanation from anybody why that would be. We're going to start with delayed orgasm. And I think the first thing to say is that there is no radical prostatectomy specific literature on delayed orgasm. And there's no indication that the rates should be different in this population than in the general population. So at the far end of the spectrum when delayed orgasm is anorgasmia. The synonyms are, which we've kind of stopped using, delayed ejaculation. There's no ejaculation post-prostatectomy. So that's why we like the term orgasm. Retarded ejaculation, inhibited ejaculation. And so we've struggled at an international level to come up with what we think is a functional definition. But the current definition is the persistent or recurrent difficulty, delay in or absence of attaining orgasm after sufficient sexual stimulation, which causes personal distress. Latency times over 25 minutes with distress or having to stop sexual activity. The 25 minutes is an interesting story because it's really 2 standard deviations beyond the average ejaculatory latency time for a man. So I don't know that 25 minutes is a be all and end all. If you have a man who all his life was 3 minutes, his ejaculatory latency was 3 minutes and he was never bothered by that, and all of a sudden he's 7 or 10 minutes, that to me is delayed orgasm in that man. Likewise, we have men who are 10 minutes with partner A and 10 minutes with partner B, but partner B is postmenopausal and 10 minutes of intercourse is uncomfortable for her. Then that's a problem for the couple. So we actually address those latter 2 cases very similarly as we would as somebody with full-blown delayed orgasm. Very, very important. Anejaculation is not anorgasmia. We have many men at this institution who are orgasmic, but who are anejaculatory. The classic example is somebody who's had a retroperitoneal lymph node dissection for testis cancer, and they are unable to ejaculate, but they're perfectly orgasmic. But many urologists will equate anejaculation and anorgasmia incorrectly. Historically, the rates are low in the literature, although in fairness, the literature is terrible. It's mostly case reports or poorly designed survey studies. If you look at Ed Lahmann's very famous US National Health and Social Life survey, 8% of men were unable to achieve an orgasm. Now that is technically anorgasmia and almost certainly underrepresents the rates of delayed orgasm. So we just don't know. If you take the causes of delayed orgasm, probably the overwhelming majority of them can fall into 5 groups. Medications, loss of penile sensation. We see this all the time in diabetics with end-stage neuropathy. They have absent poor penile sensation. Endocrine factors, chronic hyperstimulation. So the man with obsessive compulsive masturbation disorder, masturbating 4 times a day, his penis is at risk of becoming desensitized. And it's going to be very difficult for a hand to mouth or an orifice to stimulate him to orgasm if he's vigorously manipulating his penis multiple times a day. Michael Perman, I think, was the first person to introduce the concept of idiosyncratic masturbation or stimulation. The classic example are men who lie flat on their stomach on silk sheets and rub themselves back and forth. That is not replicating oral or vaginal relations or anal relations. So those patients sometimes struggle to have orgasm with the partner. And then psychosexual factors, and that's a big umbrella term of many, many different things under there. This is a partial list of drugs that have been implicated in the cause of delayed orgasm. I will tell you, 25 years in the business, the only drug category on this list that is routinely associated with changes in ejaculatory latency will be SSRIs or SNRIs. Most of the other drugs we just don't see as a cause. And remember, this literature comes from, or these reports come from medical clinics without them being controlled for a testosterone level or penile sensation testing. So it's just the best guess that the medication in most of these reports was the etiology of the delayed orgasm. But consistently, SSRIs have a role in delaying orgasm. That's why we use them very effectively in the management of premature ejaculation. From a hormone standpoint, low testosterone, hypothyroidism, or hyperprolactinemia. So on our forms here, just beside me, there's a form. It says testosterone libido panel, and it's total and free testosterone, T4, TSH, and a prolactin level. Okay, we always check our testosterone levels before 10 o'clock in the morning, and we're always using liquid chromatography mass spectrometry, LCMS, for our total levels. So sophisticated assays to really define whether the patient's testosterone level is low or not. If you're measuring free testosterone, I would strongly encourage you to think about using equilibrium dialysis. The other assays are notoriously inaccurate. And when I say inaccurate, it's because they have a very high coefficient of variation. So some assays have between a 15 and a 30% coefficient of variation. So our delayed orgasm screen is this: low T, hypothyroid, and hyperprolactinemia. So much of the literature that supports testosterone and delayed orgasm comes from the Mario Maggi group in Florence. They have a massive clinic and massive database, and they do these data mining studies. And there's a suggestion that low T was related to delayed orgasm. When they looked at their patient population, it was low T and borderline T that was associated with the presence of delayed orgasm. There was a higher percentage of men with delayed orgasm who had low T compared to men who didn't have delayed orgasm. It was about 1 in 4 of them. That is not the percentage that I see here by any means. And they had higher TSH levels and prolactin levels. So hypothyroidism, hyperprolactinemia, it's worthwhile including those blood tests in your screen for men with delayed orgasm. So compulsive masturbation, we talked about desensitization of the penis. Idiosyncratic masturbation style, this is Michael Perlman. This is a case series of 75 men. It's not controlled. There's kind of variable follow-up on how they were, what the inquisition was, what the survey was, etc. So, you know, 1/3 of them, more than 1/3 of them had an idiosyncratic masturbation history. Michael Perlman has a very specific, or had a very specific kind of practice in New York City. We have a lot of high adrenaline people in Manhattan. As those of you who've been to Manhattan, it's a fairly intense area. So a lot of high adrenaline people in the city. So that's associated with ED, but it's also associated with delayed orgasm. In a small randomized study looking at bupropion for delayed orgasm in 19 subjects per group, more men in the delayed orgasm group demonstrated idiosyncratic masturbation. So this is the sum total of the literature supporting idiosyncratic masturbation and delayed orgasm. I will tell you my clinical experience is that if somebody does have IMS, it increases the likelihood. It doesn't mean they've got delayed orgasm, but I think it increases the likelihood of them having some problem in partnered relations. Ejaculatory latency range may in fact be biologically set. So just like we have a testosterone set point, some men are 300, some men are 800 all their lives. It's likely that the IELT has in some way some biological component to it where we're set, okay? Ejaculation timing within this range may depend on psychological, behavioral factors and relationship factors, of course, okay? I tell men in my practice that to have an orgasm, you need to be in the zone. You need to be immersed in the experience and relaxed. And if your mind is distracted, if you've got ADHD, for example, if you're worried about your erection, are you going to lose your erection? If you're worried about, are you going to achieve an orgasm? Then I think you're less likely to have an orgasm. So one of the strategies we use clinically is we always try and encourage these men who have delayed orgasm to try diminish the importance of orgasm in their sexual experience, not focus on orgasm. And oftentimes they will have an improvement in their orgasmic capacity. This is the Corona study, 16,000 men, 1,600 men, excuse me. The predictors of delayed orgasm, stress at work, psychiatric diagnosis, SSRI use, low T, low sex drive, and absence of partner climax. So again, you're seeing the recurrent theme of testosterone and SSRI use for delayed orgasm. These are questions, you know this much better, most of you know this much better than I do. Your mental health professionals will have a better handle on this, but these are the things that I focus on from a psychosexual standpoint as a urologist who does sexual medicine. Is this the first relationship after being divorced? Is it a first relationship after being widowed? Are they in fear of getting their partner pregnant? Is there overt interpersonal conflict or serious performance anxiety? And these are excellent reasons why I would send these patients to see Chris Nelson, who's a psychologist who works with us at Memorial. When you have somebody who comes in with delayed orgasm, it's very useful to try figure out, is this lifelong primary delayed orgasm, or is it an acquired phenomenon? Most of the patients I see have had new onset delayed orgasm. How long has it been going on for? What percentage of the time does it occur with their partner versus on their own? So for example, if somebody comes in, we had a man earlier on this week, and he had complete inability to have an orgasm with his partner, absolute complete inability, but 50% of the time he was able to achieve an orgasm with masturbation. Now, I'm not talking he needed to spend 2 hours masturbating, but he could have an orgasm half the time and not with his partner. There are really 2 causes for that. One is penile sensation loss. We can overcome penile insensitivity or hyposensitivity by vigorous masturbation. And the other cause is psychological. So when I see men coming in who struggle having an orgasm with their partner but can on their own, I start focusing in on penile sensation and psychological factors. The other thing that's important to ask is, how long are the encounters lasting? So you have a man who all his life was orgasmic in 2 minutes. He has a short latency time. And now he can't have an orgasm. And you say, how long are you going? And he says, well, I go 10 minutes. And of course, it's 5 times longer than he has been going all his life. So it's a long time for him, but it might not be long enough. And if he tries for longer than 10, whether it be 15 or 20 minutes, some of those men will actually be orgasmic. Okay. The other thing that we see all the time with older men is they get tired. And I give a lot of push-up instructions to my patients, to my older patients who get fatigued during sexual activity. They need to build up their upper body strength so they can last longer. Sometimes they just give up because they're fatigued. Evaluation, so early morning total T level. If you're going to do that, if you have LCMS available to you, that is would be considered ideal. That's what the AUA guidelines suggest you do. We do penile vibratory sensation testing on everyone who comes in with delayed orgasm, so biothesiometry. This is a very, very easy instrument to use. It costs about $250. It's not very expensive. I think every sexual, not mental health, but certainly physician-based sexual medicine practice should have a biothesiometer. You basically apply the tip of the gun. It's like a little gun. You press the button and it vibrates. And it goes on the index finger, it goes on the penile shaft, it goes on the glands, and then at the frenulum. And there's a nomogram, and the nomogram is Cully Carson in the States is cited as, it's called the Carson nomogram, but I'm not sure his name was on the paper. But there's a nomogram, and it's somewhat age dependent, and there's parameters for what's normal in younger, middle age, and older men. And it's a very useful tool. In my experience, if you really have a penile neuropathy, your penile sensation is invariably 2-fold what the upper limit of normal is. And we have men who are literally 10-fold what the upper limit of normal is, where they're incredibly insensate. And the most common cause for that in my practice will be diabetes. But at a cancer center, we'll see many men with glove and stocking neuropathy. For the physicians out there, if you have a cancer patient who comes in, they've got glove and stocking neuropathy, let's say after cisplatin, okay, the penis is an extremity. So there's a reasonable correlation between glove and stocking neuropathy and penile sensory neuropathy also, because they're all extremity nerves. And so we see this all the time in patients with chemo or testis cancer patients who are cured of testis cancer, but their penis is numb and they have numbness in their hands and feet. Comprehensive medication history, of course, focusing on the medications we've talked about. Masturbation history. For the non-sexual medicine doctor, this is a really uncomfortable conversation to have. I think that you can't be a good sexual medicine doctor if you can't speak openly and frankly to patients about their masturbation history. They may get embarrassed, but it's a routine part of sexual history taking. And then as a urologist, it's a pretty focused psychosocial assessment. And if I have concerns, then I'll refer them out on to see Chris Nelson, who works very closely with me. The management, fairly straightforward, address any overt psychological issues, address potentially offending medications, supplement testosterone. I will tell you, in our patient population where I think a man's low testosterone is a contributor to his delayed orgasm, and we put those men on testosterone and get them to a normal T level, it's only 1 in 4 of them who have a significant improvement in their orgasmic capability. So yes, testosterone may be a contributor, but I don't think it's the most important thing. So in contrast to what Giovanni Corona and Mario Maggi would suggest, I think that even in men with low T, there are other factors, probably psychosocial factors, that are impacting upon their orgasmic capacity. Penile vibratory stimulation for men who have sensation loss, not for every man. And then pharmacotherapy. So I don't have a slide on the drugs that have been used, but there are 30 drugs that or more that have been used in delayed orgasm, most recently oxytocin and cabergoline. There is no good evidence whatsoever that oral pharmacotherapy is of significant benefit. Now, I'm on Twitter and I see these people write in all the time, oh, I have had reasonable success with using cabergoline and delayed orgasm. Half my patients do well. All right. So it's a flip of a coin, right? So anecdote isn't statistics and isn't a randomized controlled trial. So I think much of this is not evidence-based medicine, but is eminence-based medicine. So somebody famous standing up and saying something, and then people say, oh, Dr. X said this, it must be true. And that's a very dangerous thing, I think, in medicine in general and in our field. So we do not use cabergoline, okay? We do not use any oral agents in men with idiopathic delayed orgasm. The problem with the literature for cabergoline or a yohimbine or for oxytocin is none of the studies, which are tiny, by the way, they're all case reports and case series. None of the studies have been controlled for the etiology. None of them are controlled for what was the T level in the patients. Might the person's low T have contributed to the delayed orgasm? None of them have really controlled for psychosocial issues, because nearly all the studies are done by urologists, right? And so it's just a mess when it comes to literature. It's just not very good literature at all. This is a small study that we did. This is a kind of a retrospective analysis, not randomized controlled. So it just gives you a flavor that there might be a value to using penile vibratory stimulation. These are men with complete inability to achieve an orgasm during sexual relations in the previous 3 months. They had normal testosterone they didn't have to have penile sensation loss, although we only use penile vibratory stimulation now in men who've got penile sensation loss. They filled out the International Index of Erectile Function, which has a really useless orgasm domain, because half the domain, there are 2 questions in the orgasm domain. One is on ejaculation and one is on orgasm. So it's not really a robust assessment of orgasm. Of 36 men, 72 reported the restoration of orgasm. 62% had orgasm during sexual relations. And the gains were sustained at 6 months. So we do use penile vibratory stimulation, but we restrict it to men who have abnormal penile sensation. Now, this is if you see a lot of prostatectomy patients, many patients will not declare this. They won't report it, but if you ask them about it, they will declare that they have it. So this is a classic situation that the more you ask, the more you learn. So dysorgasmia, which is orgasmic pain, this is pain that occurs in and around the time of orgasm, before, during, or after. And it's usually in the genital area. It's a barrier to satisfactory sexual relations. So we have men who are 9 months post-prostatectomy and they have excellent erections after bilateral nerve-sparing surgery, and they're responding robustly to Viagra, and it's great. But they say every time they have an orgasm, they have a crippling pain in the tip of their penis, and they don't want to have sexual relations. So it's not an insignificant problem. It's an insignificant problem to cancer doctors, but it's not an insignificant problem to patients. Some of these patients may respond to alpha blocker therapy. I'll show you some data on that in a little bit. And the natural history of this condition is not very well appreciated. It invariably goes away, but that's variable. Dysorgasmia in the general population, 1 to 10% after prostatectomy in our data set. It's consistently, when we've looked at this multiple times over the course of the last 15 years, it's consistently around 14%. So it appears to be a little higher in the prostatectomy population. The 2 other patient populations where this has a relatively high prevalence would be radiation patients for prostate cancer. We see it in those patients commonly also, and men with chronic pelvic pain disorder. So men who have pelvic floor dysfunction. And that's why we believe that the etiology, the pathophysiology of dysorgasmia is probably pelvic floor spasm and referred pain, penis, testicles, perianal area, perineal, lower abdomen. Dysorgasmia prevalence in a study that we did, 702 men, 84. So 12% of men had dysorgasmia. The mean visual analog scale from 0 to 10 was 3.9. So most of the men will say this is a nuisance value, Dr. Mulhall. This is not crippling. But we do have men who have pains in the 8 level. That's uncommon. So most men are between a 3 and a 5 or so. The mean frequency at an initial interview was 4 times per month. They were having sex 4 times per month. And the mean duration of orgasm was about 7 months. But we have men who have it in the second year uncommonly. Most men who have it are going to experience it within the first half dozen orgasms, and it's going to be gone between 6 and 12 months after surgery. If you look at this, you'll see the location. Most of the men have this usually at the tip, on the glands of their penis, and then the testes or other locations. The other locations, again, as I said, perianally, perineally, lower abdomen. But we've had men with dysorgasmia that went down, pain went down their legs, for example, or went up their sides. So it's very variable. Looking at the number of men who are still complaining of pain based on time. So these are men who have the condition, the 14% of them who have it. And if you follow them longitudinally, you'll see that most men still experience it by the 6th month. But as you start going out past a year, there's a rapid drop off in it. And it's very uncommon for us to see men who had dysorgasmia early after surgery who still have it at 2 years after surgery. This is just the red dots are the frequency of the pain, and the black is the level. You can see a drop in both frequency and intensity of pain over time. This is looking at the use of tamsulosin. This is a paper published in European Urology many years ago. This is not a randomized controlled trial. And this is looking at 3 populations. Those 3 populations we talked about. Let's just focus on the green bar, which is the prostatectomy patients. But pre-treatment versus post-treatment, tamsulosin, which is 0.4 milligrams. We now use alfuzosin 10 milligrams because it's the most uroselective drug with the least effect on blood pressure. So we use uroxetrol or alfuzosin. And the mean drop in pain was 2 points. So if they start off at a 4 and they go to a 2, most men are not going to be particularly bothered by that. But it is, the entire group had a mean decrease of 2.7 points, but I think 70% of men had at least a 2-point improvement in their pain. Orgasmic incontinence, you know, this is another thing that most oncologists don't talk about to their patients. When we see somebody before prostatectomy, we say, here are the things that you should expect. You won't ejaculate, you should be orgasmic, the intensity might be different. You might have pain, 15% chance, and you have a 60% chance of ejaculating urine on at least 1 occasion after surgery. So we say in the first half dozen orgasms after surgery, we want you to have a towel on the bed, avoid oral sex. If it doesn't happen in the first 6 orgasms, it's very unlikely to happen after that. Normal orgasm, the bladder contracts. So normally male and female orgasm, the bladder neck contracts. The bladder contracts. So it's important that the bladder neck contracts so there's not leakage of urine. And then, of course, the rhythmic periurethral muscular contractions, 3 to 8 muscular spasms lasting about 0.8 seconds is typical for men at the time of orgasm. We're not going to talk about arousal incontinence, which is a very different thing, but arousal incontinence is prior to orgasm, men are just leaking during stimulation, even cerebral stimulation. They're getting aroused and they start leaking urine. And that is a sphincteric problem. There is a link between arousal incontinence and a man's diurnal continence level. So that's associated with a man who is not fully continent during the day, wearing pads. They are more likely to have arousal incontinence. There is no link between climacturia and diurnal continence after prostatectomy because this is not a sphincteric issue. This is either, and probably a combination of 2 things, it's either bladder neck problem. The bladder neck is interrupted and operated on during the surgery and takes some time to recover. And there's some early work that we've done using MRI that suggests that perhaps the urethra, the urethral length or the urethral width may in fact be contributors to climacturia. When a prostatectomy is being done, we have individual urethral lengths. There's some men who have urethral lengths that are very long, some that are very short. It appears that longer urethral length or wider urethra may in fact be healthier urethras and may protect against climacturia. So the literature suggests that up to 90% may have that on at least one occasion. Our data, our very recent data, is that 60% of men will have this on at least one occasion. Of course, it can lead to avoidance of relations and may impair their quality of life. I will tell you, in the gay population, in gay men who come in to see me, that climacturia is actually perceived by many of them as a positive in their life. Okay. Of course, the challenge with gay sexual relations versus heterosexual is that the man, the sufferer of sexual problems, has a mirror image in the bedroom, and if his partner is ejaculating and he's not, that causes distress for the patient and or partner. So ejaculating urine for some of these gay men is not a problem. This is just a review of the literature. The Judy Choi paper is our paper. There are two papers from way back when, 1996 and 2006. But really the first paper that put it on the map for urologists it came from Canada, Neil Fleschner's group, the Lee paper, 42 patients, 45% had climacturia on at least one occasion. Our data consistently is 60% of men now have this on at least one occasion, but 20% of men have this consistently throughout the first year. And it's less common in the second year and it's rare in the third year. But it can be a consistent problem for some men. Of course, there's a potential significant barrier to the satisfaction with relations. The etiology is not, pathophysiology is not fully characterized. We're not sure. What would be very interesting to do for the urologists, I saw Yuza and Alex on there on the screen. So what would be very interesting to do as from a urology standpoint would be to do urethral pressure profiles, to basically survey the pressure profiles urethra, which is technically feasible at the time of urodynamics, and see do these men have a unique pressure profile in the urethra compared to non-climacturia patients. I've already talked to you about the concept of the dysfunctional bladder neck and the urethral anatomy. This is just the data from our MRI study suggesting that urethral width, time since surgery, and body mass index are the kind of predictors of climacturia. This needs to be kind of explored further. It's hard to get radiologists enthused about doing orgasm research. Treatment, behavior modification, minimize fluid intake, empty bladder prior to sexual relations. These are pretty easy to do, but I will tell you that if you've had dinner and 2 glasses of wine and it's your anniversary and you're going to make love within the hour of that, and you empty your bladder 15 minutes before, your bladder is going to fill very quickly. So emptying your bladder is a reasonable strategy, but it's not always very effective. There's no literature on condoms, although it seems like it's an intuitive strategy. The problem with the condoms is that often these men are 65 years of age and it's 30 years since they put a condom on. And now all of a sudden we talk about the new sex, right? But this is now a big new sex phenomenon, having to wear a condom. And then of course, if they're leaking urine, and then the condom fills up. The volume of urine that's leaked is very variable, from drops, of course, to ounces. We've had men who, they don't measure it, but they'll say, listen, it looks like it's ounces and it drenches the bed. So that's not going to work well inside a condom. Imipramine has been used kind of empirically. There's no good literature on it. It's a useful drug in the sense that, or theoretically, it relaxes the bladder and it contracts the bladder neck. So if you're going to use a medication, then imipramine would be a good strategy, much better, at least on paper, than Sudafed would be, because Sudafed just contracts the bladder neck. So imipramine relaxes the bladder and it contracts the bladder neck. But I'll tell you that it's my experience when I was using, we no longer use it, was not very successful. Really, the treatment of choice nowadays in my practice is using a penile constriction band of some kind, usually a variable tension constriction band, which is more comfortable. And if used properly, this is a very useful strategy. There are many of these. We use variable tension devices for the following reason. When you're using a venous outflow controller, they need to be really, really, really tight. There are 4 ways that blood gets out of the penis: the spongiosal veins, the dorsal veins, they are on the shaft, and then the 2 sources behind, the crural and cavernosal veins. So when men are using a venous outflow controller, the reason constriction bands don't work very well in men who've got real ED is that they can only ever control 2 of the 4 sources of blood leaving the penis. This device does not need to be a venous controller. It is just to put pressure on the urethra. The urethra is a very low pressure structure. You don't need a lot of tension. And that's why the beauty of this, being able to cinch it down as tight as you need it, is very useful to these men. The problem is this: if you don't have a good erection, this will not work very well. You need rigidity of the penis to act as a backboard against which to compress the urethra. If you don't have a good erection, these devices don't work very well. However, if you have an excellent erection, if you're rigid and you apply this device, invariably you're going to be dramatically improved, or it will be completely resolve the problem. Okay? And it doesn't have to be very tight at all, because if you have a hard corpora cavernosa, the urethra just needs to be squeezed a little bit against the corpora cavernosa, and it works very well. These devices should always be rubber and never metal. It should be applied over an erection. The variable tension devices are the most comfortable, and then any penile constriction band should stay on for no longer than 30 minutes. There is good evidence, at least in animal models, that the oxygen, the PO2 level drops after 30 minutes of a constriction band being in place. This is just looking at the degree of climacturia with the active band as one version of the constriction device. And these are men who have small, moderate, or large. Small in our practice, for when our fellows come in, they learn this. As small as drops, medium, moderate is less than an ounce, and then large is over an ounce. I don't know how you can define if it's an ounce or less or more when you've just ejaculated it. So it's an incredibly inaccurate system, but that's how we grade it in the practice. And you can see here that there was a significant reduction in the amount of climacturia when using a constriction band. Finally, anhedonia, I'm not really going to talk about much. I mean, my fellows learn about it, even though they're urologists, they learn the concept of anhedonia. But the mental health professionals are going to be much more facile with having this conversation than urologists, even me. I do want to finish up talking to you about what is a very, very important, potentially medical license threatening condition in the orgasm sphere, and that's FASA. And we pick up 2 people a year who have a sexual headache, who have a serious medical problem that needs to be addressed urgently. Okay, so when you have somebody who meets the definition of FASA, it is incumbent upon you to pay very close attention to that. So it used to be called, you'll see the synonyms there: sexual headache, orgasmic cephalgia, et cetera, et cetera. But the modern terminology now, after the most recent international consultation of headache disorders, is primary headache associated with sexual activity, FASA. Okay, so according to the ICD-3, it is defined as follows: the presence of at least 2 episodes of pain in the head or neck brought on by and occurring only during sexual activity, either increasing during sexual excitement or starting abruptly and intensely before or at the time of orgasm, lasting from a minute to 72 hours, and not being accounted for by another ICD-3 diagnosis. The most common differential diagnosis is going to be migraines. And there are, the literature would say it's about 10% of migraine users who will have augmentation of the migraine at the time of orgasm. So that's a good question to ask. Do you have a history of migraines? Yes, I do. Maybe this is just a migraine. Okay. But if they don't, then you need to be worried about the differential diagnosis. FASA is a diagnosis of exclusion. You need to make sure there isn't some other cause, and a cause, hypertension is a cause, particularly very poorly controlled hypertension. And then the big one is subarachnoid hemorrhage. Okay, so we haven't picked up a subarachnoid hemorrhage in a few years, but we have picked up a subarachnoid hemorrhage, and it's very, very important. If you look down the list of these differential diagnoses here: cerebral arterial dissection, reversible cerebral vasoconstriction syndrome, intracerebral hemorrhage, these are conditions that need to be addressed. So if you have somebody come in and they meet the definition of FASA, they need an MRI of their brain. Okay. Subarachnoid hemorrhage should always be excluded first presentation. 4 to 12% of sexual headache cases are due to subarachnoids. So it's not the majority, but it is a potentially life-threatening condition. So it's absolutely worthwhile having that knowledge in your armamentarium. The medical therapy for FASA is preemptive or prophylactic. Prophylactic just means you take it every day, and that's daily propranolol or metoprolol. And there's reasonable results with all of these strategies, actually. And preemptive means I'm going to have sex tonight, I'm going to take a indomethacin or a sumatriptan, which is a migraine headache. So there are actually decent pharmacotherapeutic strategies for FASA once you make sure that they don't have some other major concerning medical condition. I think that is my last slide. This is the attention span of medical students in response to lecturers. The solid line is the mean, and it peaks at 12 minutes. Thank you very much.
Those are medical students. I think that professionals, maybe it's even worse than that. Thank you, John, so much for a very comprehensive and super interesting talk. We have a few minutes for questions. I have a few, but I'll leave the stage for other people if you have any questions, because it's there are a lot of things that.
Hello?
Chezi?
Ken.
Dr.
What about orgasm in radical cystectomy in women?
Yeah. So I deliberately didn't touch on female orgasm today because it's been quite some time since I've really managed women. I used to, but quite some time. If you look at radical cystectomy, the extent of that operation is massive, even compared to a prostate. If you look at the literature on male or female sexual function, it is very, very disappointingly poor, right? So I'm not aware of any specific literature that has addressed female orgasm post radical cystectomy. The thing that is in the literature most commonly is that the classic radical cystectomy may take a vaginal wall, right? There is a move among younger cystectomists to not do that without there being any higher rates of cancer recurrence. But when that is removed, then the women get vaginal stenosis, and that becomes a real problem. And that would certainly be a contributor to orgasmic dysfunction as well. But I don't know what the current literature says about female orgasm. You'd have to speak to, some of the issue-ish people. Maybe Mulhall knows the answer to that. We have a 5-year project that is coming to its termination here, acquiring massive amounts of sexual medicine data, about 250 questions given to men and women after cystectomy. So I'm hoping that we'll have some information in that will help answer your question.
John had user head. Good. The people after brachytherapy are complaining more intensively on the pain after ejaculation. Do we have any explanation for it?
So it's definitely in the literature. It's not just about brachytherapy. It's definitely in the literature that there is a dysorgasmia rate after radiation therapy. If you believe that dysorgasmia is the result of pelvic floor muscle spasm, which I think it probably is. So for the men in the audience, if you've ever been at a football game and it's halftime and you're trying to use the bathroom and there are 13 guys behind you saying, hurry up, user, sometimes you can't go. And that's because of bladder neck spasm. And when you can finally go, frequently that's associated with pain at the tip of your penis, right? And that is what I believe dysorgasmia is. It's pelvic floor or bladder neck spasm. So if you're manipulating the bladder neck or traumatizing it, which you will do with brachytherapy, we all know that even in the hands of an expert brachytherapist, even using stereotactic guiding, that there are seeds that go in places they're not supposed to go. So I think it's probably bladder neck or pelvic floor irritation from the needle placement. I'm amazed that there isn't instant erection problems after brachytherapy, which there really isn't. But it's a relatively traumatic procedure. And it's hard for me to believe that the nerves don't get bruised and swollen immediately after the procedure, but they appear not to be, because people tend not to get an ED immediately after radiation therapy.
What we found that after brachytherapy, the dysuria and urination problems was much higher in the patient and longer. and same patient had more intensive pain than the other normal patient without the LUTs.
It's almost unheard of at Memorial Sloan Kettering for a brachytherapy patient not to leave the hospital with an alpha blocker. So they're all immediately put on tamsulosin or elafusicin.
Yeah.
So I expect that might shield, you know, might shroud the incidence of orgasmic pain in that population. Listen, I think there's a lot of work to be done in the radiation patients, for sure, research-wise.
Yeah.
I think we have time for one last question, if anybody would like to ask anything else.
Can I ask something if no one is asking? Hi, I'm Dana Livne.
Hey, Dana.
Can I ask you something about post-vasectomy pain, orgasmic pain? Well, this is something that I see sometimes, and I would be grateful if you can tell me something about it.
It is the bane of urologists. When you do a vasectomy, it's not a routine thing, but it's a significant minority of men. If I remember correctly, it's less than 10% of men who get post vasectomy pain. And so there's a whole algorithm that you go through to try to find what the etiology is. So you have to make sure that's not neuropathic, because when you're clipping the vas deferens, you can clip a nerve, right? It might just be spasm of the vas deferens, okay? So typically what we end up doing in these men is we will give them a spermatocord block and then send them home to have an orgasm.
So I'm not talking about the testicular pain, which I'm familiar with, because I was in the clinic with Dr. Jarvie, so we did a lot of them. But I'm talking about the orgasmic pain, not the testicular pain.
So when we have an orgasm, our vas deferens and our epididymis contract. There's not much muscle in the epididymis, but there is huge muscle in the vas deferens. So, you know, in a normal man, the epididymis contracts, the vas deferens contracts, the ampullary vas, the seminal vesicle contract, and the periurethral musculature contract. So it's very reasonable to believe that the pain, if it's orgasmic in those men, is related to the vasal contraction. The question is, what are you going to do about that? And I think I would just use an alpha blocker, right? That will relax that muscle to some extent. Alpha blockers are fairly uroselective, so I'm not aware of the basic science whether it would work well on vasal muscle. But if you look at a cross section of the vas deferens, it is 90% muscle, 90% muscle. So that's a strategy that I would consider using. I don't do a huge number of vasectomies, so I don't see that problem very often. And I can't remember the last time I saw somebody with orgasmic pain after that. Do you see this regularly?
Sometimes it's not usual.
Yeah. It's not very common in my practice, although I'm not the most prolific vasectomist in New York City. But.
Thank you.
So John, again and again,
My
thank
pleasure.
you for your generosity with your time, your knowledge.
Bear with you. So I look forward to coming back sometime in the future. I had a beautiful experience there several years ago when I was at the Israeli Urology Society meeting. So I look forward to coming back, everyone.
Thank you so much.